Thank you, ma'am, for that kind introduction. At the outset, I would like to thank Dr. Rohit sir and everyone on the team for making me part of this IC. So today, these series of cases, I call them the little things matter. In these series of cases, I would basically describe the small lessons which I have learned during my fellowship and how they have helped me treat my patients better. So the first case is a case of 60-year-old male who had come to me for complaints with blurred vision since 3 to 4 months, which was gradual, progressive, and painless. He was already consulting 2-3 doctors elsewhere, and he was being advised cataract surgery. So on examination, it was seen that right eye, the vision was 6.9 and the left eye was 6.24, which wasn't improving. Rest of the anterior segment was normal. In the right eye, the lens showed NS1 grade cataract. The left eye showed NS2 with PSC. And on examination of the fundus, it appeared grossly normal. Now, this patient had no systemic illness, and I advised him cataract surgery in the left eye. This patient particularly wanted freedom for glasses. One, he was not very keen to wear these glasses. And secondly, also because he had insurance and he wanted to make the best use of it by putting the premium lens. Now, as we have been taught in the fellowship, the workup for any premium lens started with a dry eye workup where Schirmer's test was done, PBUT was done, and after that, corneal topography was done, which was normal, and the astigmatism was less than 0.75. So a multifocal IOL was planned after counseling. But here is where a very important lesson which we learned during our fellowship came. Was this workup complete? No, the OCT was still remaining. As Chaitra ma'am rightly said in her talk, OCT in cataract patients preoperatively becomes very important, especially in these premium cases where they want premium lenses. So this was what the OCT was showing for this patient. There was a pigment epithelium defect. So after retina consultation, the multifocal IOL plan was deferred and a monofocal IOL was planned under guarded visual prognosis. So the little things which matter here is never to forget the checklist which we have been taught every time that any patient comes for a premium surgery. There has to be a detailed history and examination, a proper dry eye workup, corneal topography, biometry, and OCT. And of course, a proper systemic workup. Coming to the second case, this is a case of 53-year-old female who was referred for problems in disc and disc basically. So for glaucoma and retina evaluation, the patient came from nearby city from Nagpur. The patient was complaining of decreased vision gradually over 1 year, and she had no other systemic illness. On examination, her visual acuity was 612 in right eye, N8, and the left eye was 624, N8. The anterior segment was quite normal and there were no cataractous changes. So the anterior segment findings did not match the vision. Also on posterior examination, there was mild pallor of the disc in both the eyes. Rest of the fundus appeared normal. Now, since the patient was specifically referred for glaucoma evaluation, there was disc pallor and decreased vision. I planned HFA 30-2. On HFA, this was the picture which was seen. Now, looking carefully at the patient, the face and the hands which previously appeared normal now appeared to be pathological. This was how her face looked. It was a acromegalic facies. There were broadened hands with excessive soft tissue. When on asking again about the history of such features, the patient said that she had previously also complained about this to some other physician who had just told her that she had calcium deficiency and was just given calcium supplements. And that is how she was continuing since so many years. So MRI brain was planned and neurology opinion was taken. On MRI brain, this is what we found, that she had pituitary macroadenoma, which was 40 mm large, that is approximately 4 centimeters. And this was not taken care since so many years. So it was a long-standing tumor which was missed at several checkups. It was already affecting the vision, and if now left untreated, would lead to blindness in her. So surgical excision had now become mandatory for her. So eye, as we all know, can be window to brain. So little things like looking at the facial features, the hands, taking the history of the patient becomes important to find out bigger problems lying underneath. Now, this is another case. This is an old case which I had seen during my fellowship. It was a case of 20-year-old male who was post-LASIK and had come to Narayan Netralaya with all these complaints of ocular discomfort, intermittent glare and halos, intermittent ghosting and doubling of vision since 2 years. So we went ahead and asked the history. We also found that he was not very happy-go-lucky kind of personality and had little problems like depression and anxiety intermittently. On clinical examination, the unaided vision was 6/6 for him. The retinoscopy did not show any significant refractive error. The extraocular movement were full and free, and there was orthophoria for distance and near. Now we went ahead and did the dry eye workup. Schirmer's for both eyes was pretty normal, the Schirmer's 1 and Schirmer's 2. TBUT was also within normal range, and there was no ocular stain. And on meibography, there was no gross loss of any glands. So what was the reason for doubling of the vision or ghosting of images? As sir already mentioned in his talk, where we begin our IC, it could be due to decentered ablation, or was it because of pseudo-accommodative spasm, which was again not there when we saw on eye trace? Then could it be because of abnormal tear optics? Again, the dry eye workup was also normal, and on OCAS also, it wasn't there. Now, the next important thing which we have been talking throughout the IC was orthoptic evaluation. On orthoptic evaluation of this patient, it was seen that the accommodation and the vergence was low. So this was a dysfunction of vergence facility. A simple exercise and maybe little bit of counseling for this patient helped him to relieve his problems. So the little things like orthoptic workup should not be missed. Now, this is another case which I'm particularly presenting for seeking opinion from everyone on the panel. This was a case of 22-year-old female who had come for refractive surgery. She was pursuing her master's as well as doing job in US and has come to India during the lockdown period. And she planned to get her refractive surgery done. So here we are looking at a girl with glasses with high screen time of approximately more than 14 hours. This was her refractive error. So she needed basically a refractive surgery only in one eye, that is right eye. Now on anterior segment and posterior segment examination, it was pretty normal. And on systemic examination, she was a case of acne rosacea and was on treatment. This was her topography, which was pretty normal again. I counseled her for LASIK, trans-PRK and PRK, and also explained the possibility of dry eye looking at the profile of the patient with high screen time. The patient opted for trans-PRK. The surgery went uneventful and I used MMC for 35 seconds. Post-operatively, she was started on antibiotic, but post-operatively, there was little delayed epithelium healing and I could remove contact lens only after a week. After removing the contact lens, there was slight epithelium heaping in the center, which resolved gradually over a week. The vision after 3 weeks of surgery was 6/9, but the patient was still not very happy with the vision. And she complained that it is not very crisp and clear. So I continued the steroid and lubricants and added cyclosporin eye drops as well. The steroids were slowly tapered over 8 weeks. After 3 months, when she presented, she still had vision of 6/9 parts, and she was still not happy with the quality of vision and complained of blurring of vision. This is what was seen on anterior segment examination. There was a mild corneal gaze, and this is what was the OCT picture, anterior segment OCT. Now, my question is, it was a low myopia case. Everything, all the ocular examination was normal. The ocular surface looked pretty normal. The surgery went uneventful. So why did this patient ended up in haze, even though MMC was used intraoperatively? I searched for literature and could not find any association in particularly between acne rosacea and PRK haze.
So I think can stop this is clear, and we'll discuss this case. We have 5 more minutes before Pooja joins. We're well within the normal time because she has just 8 minutes present.